for Clinical Operations. Thank you. And Dr. Scotte Hartronft, Acting Executive Director of the VA Office of Geriatrics and Extended Care. As a nation, we have a solemn duty and a sacred responsibility to support and care for the men and women who have defended our nation and protected our values. In my role as chairwoman of this subcommittee, I'm deeply committed to honoring the charge from our nation's 16th president that is etched on the front of the VA headquarters, to care for him who shall have borne the battle and for his widow and his orphan. And of course, we can gender neutralize that for the 21st century, but there is no mission more important than that. And under my leadership, this committee will own and honor it. And I think the ranking member would join me in that feeling. We're also going to update that mission to reflect the brave women who are now a part of it as well. Veterans who are living longer have a greater diversity of needs, and we need to be meeting them in more diverse ways. The facilities that I've visited in South Florida, some of which are in my district, provide decent levels of care, but that's not true everywhere around the country. A recent USA Today and Boston Globe investigation found disturbing cases of substandard care at VA nursing homes and unsettling efforts to keep those assessments quiet. I will work closely with our veteran support groups to address these issues. Quite simply, it's unacceptable. Anyone who risked their life for this nation should never have to risk it again inside a nursing home. The Office of Geriatrics and Extended Care is committed, I know, to providing options for veterans to choose which type of care works best for them at the individual level. And the VA is required by statute to provide institutional nursing home facilities, but that might not be the best option for every veteran and their family. Again, it's the 21st century, and a one-size-fits-all solution for someone in their retirement years is inappropriate. Veterans should have choices if they want to age in place, and I know that you both are committed to finding the best option for each individual veteran. Dr. Boyd and Dr. Hartronft, I would like the hearing today to be more of a conversation, ideally, regarding the long-term care needs of our veterans. We want you to highlight the great work that you both are doing at the VHA and your employees along with you, and shine some light on these important issues where things are falling short. So thank you for both for being here today, and I look forward to your testimony. And now I'd like to recognize my colleague and friend, the ranking member, Judge Carter.
Thank you very much, Madam Chair. And folks, welcome. I want to thank our chair for holding this hearing today, because this is a very current event in healthcare today. I appreciate that we started a conversation on the issues that challenge our veterans in my district, in the state, and around the nation. And by the way, this issue is really a current event to all American seniors, of which I happen to be one, and their families. America's population is aging, and our veterans are aging. As we age, our health care needs change, and specialized care and different access is very important. The health care options that you offer are pretty well what is recommended, I would say, to everybody. And I read an interesting article, you may have seen it, I believe it was last week, or week before last, in the Wall Street Journal, about where people want to die. Did you see that? And they want to die at home. So the over 80% of the seniors they were relatively healthy, but the question was asked of them, if you had a choice, where would you want to die? And 80% of them wanted to die at home. So having extended care is an important issue to Americans, not just our veterans, but to Americans. And I know we're going to have a conversation about that. The Department of Veterans Affairs, I would say, has been a leader on these issues. And I look forward to our discussions today and working together to support all veterans, because all of us age and all of us face this in the future. So thank you for being here. I look forward to our discussion.
Thank you so much. I need four hands today. Dr. Boyd, I know that you submitted written testimony, and that'll be included for the record. You are recognized for 5 minutes to summarize your remarks.
Thank you very much. Good afternoon, Madam Chair, Ranking Member Carter, and distinguished members of the subcommittee. I appreciate this opportunity to discuss VA long-term care for veterans and their choices for care as they age or face catastrophic injuries or illnesses. I'm accompanied today by Dr. Scotte Hartronft, the Acting Executive Director for the VA Office of Geriatrics and Extended Care. VA's Office of Geriatrics and Extended Care, or GEC, is committed to optimizing the health and well-being of our veterans with multiple chronic conditions, life-limiting illness, frailty, or disability associated with chronic disease, aging, or injury. GEC's programs maximize each veteran's functional independence and lessen the burden of disability on veterans, their families, and caregivers. As in the case of the World War II veteran, airplane mechanic, and retired country physician diagnosed with debilitating Parkinson's, whose care was delivered by occasional admissions to a community nursing home, assisted in the home by homemaker home health aide, and the support for his spouse with respite care. Or that Vietnam veteran, West Point grad, with devastating diagnosis of metastatic lung cancer, who was able to spend his final days in his home under hospice care with family. And finally, the 33-year-old Navy veteran with a lifelong medical diagnosis who no doubt will rely heavily on our VA system of care as he ages with a chronic disease. As veterans age, approximately 80% will develop the need for some long-term services and supports. The aging of the veteran population has been more rapid and represents a greater proportion of the VA patient population than observed in other healthcare systems. GEC's programs include a broad range of long-term services and supports, one of which is home and community-based services. This program supports independence by allowing the veteran to remain in his or her own home for as long as possible by using one or more of those services, including adult day health care, home-based primary care, homemaker home health aide, palliative and hospice care, respite care, skilled home health care, telehealth, and veteran-directed care. In addition to improving care for veterans, home and community-based services reduces costs for the department. VA financial obligations for nursing home care in fiscal year 2017 reached $5.7 billion. The number of veterans with service-connected disabilities rated 70% or more, for whom VA is required to pay for nursing home care when indicated, is projected to double from 500,000 to 1 million veterans between 2014 and 2024. Therefore, if nursing home utilization continues at the current rate among our veteran enrollees without any consideration for inflation, the cost to VA for providing nursing home care for enrolled veterans can conservatively be estimated to reach more than $10 billion within the next decade. There's an urgent need to accelerate the increase in the availability of the services since most veterans prefer to receive care at home. And VA can improve quality at a lower cost by providing care in these settings. States have found that through their Medicaid programs, they have been able to reduce costly nursing home care by balancing their expenditures for long-term services and supports between institutional and home and community-based settings. Nursing homes are settings in which skilled nursing care is available 24 hours a day. All veterans receiving nursing home care through VA must have a clinical need for that level of care. VA strives to use nursing home care when a veteran's health care needs can no longer be safely met in the home. VA also maintains strong working relationships with the states and the oversight and payment of veterans care through our state veterans homes. There are currently 156 state veterans homes across all 50 states. We continue to recognize and appreciate the commitment of our partners there. VA's various long-term care programs provide a continuum of services for older veterans designed to meet needs as they change over time. Together, they have significantly improved the care, well-being, and dignity of our veterans, including that World War II veteran. He was my father. The Vietnam veteran, he was my eldest brother. And finally, the 33-year-old Navy veteran, he is my stepson. The gains in the long-term care provision of care would not have been possible without consistent congressional commitment in the form of both attention and financial resources. Your continued support is essential to providing high-quality care for our veterans and their families, present and in the future. Madam Chair, this concludes my testimony, and my colleague and I are prepared to answer any questions and get into a conversation.
Thank you. Dr. Hartronft? Okay. Well, I appreciate your overview of the long-term care service that is provided to our veterans. I think long-term care has really evolved over time. You know, I think long before I was even born, and then on into, I was born in 1966, and so, you know, decades ago, institutional care, whether it was for seniors or for the mentally ill, was, or any other type of person with a disability, we had a warehouse mentality. And, you know, as a Floridian and someone who represents a district that is, has a tremendous population of senior citizens, 33,000 veterans in my congressional district alone, many of whom are retirees, we obviously can't meet the needs of our senior population, or almost any population that has needs for services, through an institutional setting exclusively. So can you talk about the long-term thought process of the VA? As I said, we have, you know, facilities that we can be proud of in South Florida, but that is not the case, and there have been some pretty horrendous stories that we've heard about substandard, are you okay? About substandard care. So where is the VA going in terms of your planning for taking care of our veterans' needs as they age?
Sure, so thank you for that question and for engaging us on this. About a year and a half ago, the administration embarked on looking at that exact question. Not that we hadn't been thinking about it earlier, but listening to our veterans and the families and the caregivers, and looking at the trajectory of where we were going and this aging population with multiple comorbidities. So we have something, and you may not have heard about it, and if so, my apologies, Choose Home Initiative, where we actually have brought together the geriatric specialists, primary care specialists, mental health, caseworkers, social workers, nursing, telehealth, all of those folks, and veterans as well, saying, what can we do? What are we doing well? What can we do differently? Because we've heard you. You do not want to go into an institutional or a residential type setting. And so we have that initiative going. We have formulated and worked with our Veterans Experience Office as well, Dr. Linda Davis. And we now have a Center of Excellence set up in San Antonio. There are 5 medical centers that are involved in that pilot, funded for 5 years. We are doing research on what worked well, what do we need to do differently. What we are finding in our preliminary work on this is that if we upfront to the left of that need or that decision in the past of going to a nursing home, what can we do to keep that veteran at home with their family? What kind of services do we need to plus up? What other things do we need to do? And how can we be savvy as a clinician, an overall clinician, to ensure that they have those services preemptively, so we don't have to just rely on institutional care? That's not what our veterans want. It's not what they need. It's not what they deserve. So we are working on that. It's going to be, we do believe that we're going to shift that. We're going to shift that curve. We're going to shift where we're spending money. We have already seen a trend line of a decrease in our nursing home costs. Only rose about 3%, where our non-institutional care, our home and community-based services, actually the expenditures rose 23%. So we're doing the right thing. We are shifting that curve down already.
So home care and community-based services are an option available to any veteran currently?
Absolutely. It's part of the benefits package, absolutely. And it's probably not, we need to do a much better job likely of informing folks and all of the clinicians and the providers and the staff that interface with any of our veterans about those options.
How well advertised is it, for lack of a better term? Because I can tell you, I couldn't name a veteran in my district that gets those kinds of services, although I'm sure they exist. And I'm not sure that my staff who handles our veterans casework would be familiar with it either.
So as a clinician, and being in the front line, I was in the private sector, but then came into the VA. This is part of what we do. These are options of care. They're part of our toolkit, if you will. So we have those conversations with our veterans and their families. But more importantly, it's likely that our veteran services organizations can actually help with some of that as well. We can get that message out differently as we push this initiative out as well. We can get more information out there. I'm sorry about the
No,
time.
it's okay.
Okay.
Thank you. Thank you, appreciate that.
Yeah.
Judge Carter?
Oh, that's very interesting, and let me ask you a question. And others here are from places that have wide open spaces. And we're famous for those where I come from. And, like, for instance, the largest concentration of the second largest concentration of people who volunteer for the services in Texas is the Rio Grande Valley.
Yes, sir.
There's no hospital in the Rio Grande Valley. They're all done by clinics. We need a hospital in the Rio Grande Valley. But their hospitalization is in San Antonio. That's 140 miles away. And that's close in Texas, okay? But I mean, I've got friends that live in Ozona. Ozona is 350 miles from El Paso, 300 miles from San Antonio. And yet, there are very many people that I know that have served. They live in Ozona. And I'm just picking those towns to show, how do we deal? I mean, they got a little bitty hospital in Ozona. I think it's still open. But I mean, how do you get those people to do the in-home work that far away from concentration of those kind of caregivers are obviously going to be in metropolitan areas, right? How do you get them to go out to way out in the boondocks and be 24-hour service? I mean, that's an issue.
So I like to start at homemaker home health and skilled nurse, some respite. We have those scattered around the entire country, so we know where those are. Those clinics, those big clinics down in the valley, know who to contract with, know who to pick up the phone and call. So that I feel very comfortable with. And I will pass it off to Dr. Hartronft to see if I miss anything specifically to your question.
Yeah, I agree. The nice thing about having those CVOCs in the Ozona is the fact that they're usually local folks that also know the area, they know the vendors. They're the ones that can actually, no matter where the larger medical center is they actually know the geography and the local everybody, so the vendors. So our process moving forward, especially as part of the Choose Home, is actually to improve the process of making it easier for vendors to encourage more, so that, some areas that is quite a challenge both for private sector and the VA to find some of those resources. But our goal is to actually be more proactive to sign up folks in the community to help us.
In the western part of our state, for instance, we have rotating emergency services. So, I mean, not every little hospital has an emergency room. They have an emergency guy that comes in for like 2 days, and then he moves 150 to 500 miles away to the next place. And the closest place to Ozona would be San Angelo, which is still about 100 miles. Just curious, because it's a difficult problem for providing anything, quite honestly. There's 5,000 people in the whole county, in Rockett County.
Yeah, many times we also partner with the states it's not just a VA, it's really us collaborating with all aspects of the community and the state. Most of the area-wide agencies on aging, we also work with the Administration for Community Services, which is part of HHS. So it's always been a true collaboration with all resources for us to really give the most options to the vets.
Well, that's good. Thank you. Thank you, Madam
Thank
Chairman.
you. Thank you very much. Mr. Bishop?
Thank you very much, and let me welcome you to the committee. I'm sure that you know that long-term care costs can add up pretty quickly. Thank you. For the veterans and surviving spouses who need in-home care, or they're in a nursing home, it can be a pretty serious financial burden. The VA has an underused pension benefit called aid and attendance. And it provides money to those who need assistance performing everyday tasks. even veterans whose income is above the legal limit for a pension may qualify for the aid and attendance benefit if they have large medical expenses for which they don't get reimbursed. Do you have a sense of why this particular benefit is underused and what the department is doing to market or spread the word about its availability? I have a number of constituents who are trying to get aid and attendance, and is it because of the slow processing that they don't have availability, or are there some other reasons?
So that's an excellent question, and I thank you for that. That benefit, that aid and attendance adjudication is under the Veterans Benefit Administration. So we will definitely take that back, that question back for the record, and we will get back to you. Absolutely.
Okay. The war-related costs of today's veterans, particularly Iraq and Afghanistan, are extraordinarily great because of the differences in these wars and previous wars. Obviously, many of the veterans who survive injuries today because of improved medicine and treatment would have been killed in past wars, and they've had to deal with IEDs, and which have caused polytraumatic injuries, multiple amputations, brain, facial trauma, blindness, that require decades of rehab and treatment. Looking forward to 2035, the veterans of Afghanistan and Iraq will be middle-aged. They'll have health issues much like the Vietnam veterans experience today. They'll have the comorbidities of post-traumatic stress, traumatic brain injury, polytraumas. How is VA going to address this? Do you have a long-term planning process in place? Are you tracking the demographics on that, particularly with these comorbidities?
Yes, sir. Part of this is, again, especially with the younger generation, with the more recent eras of service, again, part of this is back to the Choose Home initiative. And we have found the rare combination of keeping people at home also improves satisfaction. It provides them choice, but it also is much less expensive than nursing home care. I think some of the culture, as was mentioned before, as to the limits between being able to be at home and versus institutional care was much gray in between. So what our goals is to continue that model as to providing the care, whether it be by telehealth, whether it by the home health services. And we've shown that with the already over the FY15 to FY18, they increased the uniques by 23% in the non-institutional care versus the nursing home only went by 3%. So it's, and then we're also doing research with our geriatrics research and education and clinical care centers to really look at those comorbidities, whether it be traumatic brain injury, because we're really dealing with a population that, as you add comorbidities with aging, of course, that makes it an additional challenge with that. So I think our first efforts with this, again, is to change our models to where we keep people at home where they choose to, and that also does help our expenditures as well at the same time. And we'll learn as we go along, and we are with the veterans as to, from Vietnam and other ages, as to when the incidence of comorbidities tend to magnify and worsen compared to the population.
You have a long-term plan to deal with that? Are you tracking those folks and projecting?
Yes, sir. We have the number of veterans by that era, and we also know by what priority categories and comorbidities. And we're currently doing research and finding how to accommodate those increased comorbidities with age.
Thank you. I'm sorry.
Oh, just add one thing, if I could.
Please.
Of course. You will hear later on, I think, in one of your other hearings about the whole health initiative as well. You know, how we start the goals of care very early in our patients and our veterans' lifespan. So hopefully, if we do this right, they will be healthier, even though have more, combat issues. They will be healthier and more agile and more independent as they age than if we did the same old, same old.
Thank you very much. Mr. Rutherford?
Thank you, Madam Chair. First, Ms. Boyd, I want to say thank you, and you as well, Doctor, for your service, but particularly for your family's significant service. I want to go back and touch on something that the chairwoman asked about earlier, and that is, new initiatives like the home initiative, some of the caregiver programs that are out there now. How would you characterize the VA's ability in educating those individuals who are already out there? How well do we do in reaching them with some of these new opportunities that are there? How are we doing with that?
Well, I think it's always a challenge, and I'm amazed at the different positions I've held in the VA over the years as to how much one would think the information's already out there. But partnering with our veteran service organizations and some of the organizations, the community veterans engagement boards that many of the VAs have. So I think what I've learned over the years is there's really not ever enough communication about these programs because again, with my own father who's going through aging and stuff as a veteran, it really is challenging and amazing as to what we think is already out there. One of the things we're trying to do is actually be more proactive. We're actually creating a model using algorithms where we can determine those at most risk of needing nursing home placement, so we can proactively reach out to those veterans based on their comorbidities, based on their age, based on other demographics and issues, so that we can actually make their primary care provider know that this person is at increased risk, and again, therefore, make sure that we intervene earlier in the process than waiting until it becomes so imminent that it happens. So,
and I agree with you, and I think the real challenge here is to make sure that those caregivers that are out there, because they are a real force that we need to tap into. But sadly, as you know, many of those caregivers die off before the veteran. How well do we reach out to those vets to get them to move from home care, for example, into our nursing home type situation?
Well, again, a lot of that happens at the primary care provider level, especially if significant issues, especially as you age, if loss of a spouse, a loss of many other, especially your support system. So it's so individualized as to how significantly available they have when it comes to social support networks.
Do you see a big difference between like an urban area where you may have a lot of VSO activity versus somebody who may be out in some of the places that the judge was talking about, where they're really kind of out there on their own? Do we focus on them particularly, or?
Yes, I would say that is a challenge, and so we're always trying to think of ways of how to improve that communication. And a lot of times those community-based outpatient clinics, the CBOCs, like out there, are some of our best ones at because they know the local population, how to get the message out to them. Is it a coffee shop? Is it a veterans town hall? Is it what is the modality of that? So that's what we rely on.
And last, I know back home, I've met with several of our VA staff back in my district, and I know VA is kind of leading the charge on getting away from all of this opioid prescription. And can you talk a little bit about how successful that move has been for VA, getting away from all of the opioid scripts that were being written in the past?
I wish I had the exact statistics for me today, but we have shown significant improvements. And part of that is the processes, because again, part of this whole health that Dr. Boyd had mentioned was really looking, I mean, the philosophy, I'm also a hospice and palliative care doc as well as geriatrics, and the philosophy of pain treatment has really changed. A lot of chronic pain and how to treat those are just so much different than we used to think, maybe even 10 years ago. So I think part of it is many of these whole healths, whether, you know, seeing veterans doing yoga, you see veterans doing, you know, battlefield acupuncture. There's so much more now that we've actually understanding the disease process that we've been able to intervene on. And I think it's
How
much
has it been
safer.
accepted moving away from, you know, a policy of no pain to tolerable pain?
Yes.
How's,
Yes, and I think partly, again, I think part of that goes back to the understanding what specific disease process is causing their pain. Because as you said, sometimes, and especially what is their quality of life and what are their expectations in their day? Because as you know, many times just increasing a pain medication may not get them at the end of the day what their goal is as an individual versus what is, and everyone's pain levels are so different. So really at the individual level, we find out what is an acceptable level.
thank you. I'll yield back, Madam Chair.
Thank you, Mr. Rutherford. Mr. Cartwright? Oh, and before I turn it over to Mr. Cartwright, they're going to call votes between 3:15 and 3:45. Is one round okay with everyone? So, or that way we'll try to wrap up. Yeah.
It's here.
Okay, good. Mr. Cartwright? Thank you.
Thank you, Madam Chair. And thanks, Dr. Boyd and Dr. Hartronft for being here. I just have 3 areas of questions. My district is in northeastern Pennsylvania. We have some very rural communities, and as I look around the table, I see representatives of other very rural communities. So it may be a topic of general interest. And the topic is telehealth, which is a critical tool for connecting rural communities with health care. And you have that listed under your home and community-based care list of items. I know that the Department of Veterans Affairs conducted a milestone 1 million video telehealth encounters last year alone. The question I have is, how can the VA continue to expand this program and build on its success? And maybe that's a question. Is it successful, in your opinion? And how can Congress support that work?
So I'll take first stab at that, and thank you for that, for recognizing that. That was a huge milestone. Expanding the use of telehealth is extremely vital in what we're here talking about today, especially as we keep our veterans at home where they want to be, safely, of course. Our use of something as simple as an iPad, something as simple as something that we all walk around with as a mobile device, that we can check in with them, they can check in with us, and we can, especially if we've discharged them from, say, a hospital, and they've gone maybe to a short stay in a facility for a bit, for rehab, let's just say, but we can check in with them once they get home, and hopefully, either through the nursing checking in, through our nursing telehealth program, or the actual provider, or someone else among the team, we can maybe pick up on small indicators of maybe something going south a bit, and bring them back in, or change that quickly, so it wards off
Nip a lot of things in the bud that way.
It will, and
Yeah.
there's a lot to be said for
So
senior
how can
personnel.
Congress help expand that success?
So we have folks much smarter than I am working on this in Connected Care that are actively involved with interfacing with Congress and in multiple venues. There will be a lot more coming out from the Connected Care folks as well. It's an exciting field. We have a lot of private partnerships as well. People really in the community want to step up and do the right thing for veterans. So I think we're very, very blessed there. So we'll get more specifics if you like.
Yes.
Okay, sure.
Yes, and you don't have to answer it all in 30 seconds or less.
Sure, I know, I was kept pushing.
All right. Number 2, caregivers are a critical support system for veterans. And Dr. Boyd, your testimony pointed out the average number of potential caregivers per older adult is dwindling. It's currently 7, but it'll drop to 4 in 2030. According to the VA Office of Inspector General, spending on the caregiver support program increased 321% between fiscal years 2012 and 2017, largely because of increased enrollment in the Family Caregiver Program. OIG found some serious management issues with the program that I find very concerning, including long wait times and improper payments. What is the VA doing to ensure caregiver programs are ready to meet the needs of an aging veteran population and a shrinking caregiver population?
So again, I know that I sit in on many of these meetings as well. There is a full group working, many groups working on the caregiver as well as the aspects of the Mission Act on that, which actually goes lockstep with what we're trying to do within the long-term care setting as well. They're actually very synergistic. We are looking to make add more clarity to the actual requirements, eligibility, and adjudication of those. But for sure, that is going to be an extremely important part of allowing our veterans to be at home, as well as another caregiver aspect would be also something slightly different than that, but it's already out there, and that's the veterans directed care as well. And that uses more of the veteran directing care of who they need, what type of services that they need in their home as well, kind of a caregiver surrogate, if you will. So
Let's keep talking about that, too.
Okay.
Okay, the third question is, as you know, the VA and Apple announced this week that veterans will soon be able to access their VA health records on their iPhones, and you discussed some of the advantages this has for veterans, and what measures the VA and Apple are taking to ensure that this data is kept private.
Again, that's a very good question, and people are working on that. That's definitely out of my lane, but we can surely get that information back to you. Very important for us to secure the extremely sensitive personal information of our veterans. I do not know all the technical aspects, but we have people working on that as well. Be glad to get that back to you.
Look forward to it.
Great questions.
Thank you, Doctor.
Thank you, Mr. Cartwright. Ms. Roby?
Thank you, Madam Chair, and good afternoon, and thank you for making time to come and speak to our Appropriations Subcommittee today. And Dr. Hartronft, thank you for your service to our country, and both of you for your continued dedication to help our veterans. You need to know I'm very, very passionate about veteran health care, and my district in Alabama falls under VISN 7. Within the VISN, it is the Central Alabama Veterans Healthcare System. We call it CAVX. My concerns are specifically that Central Alabama system is failing and continues to fail our former men and women who dedicated their time, their lives, their families, their careers to give to our country. We promise to give them the best mental care, the best physical care, the best eye care, the best dental care, and we aren't. The Central Alabama VA system has continued to be a one-star facility, and based on the Strategic Analytics for Improvement in Learning, or your SAIL data, it doesn't appear to be improving. I cannot sit here and accept the fact that there is the status quo under this SAIL data bell curve that some of our facilities have to remain a one-star. That's just not acceptable. And I also think that CAVX is, being a one-star, is considered a Category 1 facility, meaning it's critical and it should receive the most attention of any of the VA facilities. And so if that is indeed the case, why is the environment there not changing? Why are we consistently at the bottom of the country for VA medical facilities? Why do 50% of visitors not recommend coming to our medical center? Why can we not greet our vets with a smile and a hello? Why don't we have enough physicians? We're not giving our veterans what they deserve and what we promised them. Something has got to change. And I don't know either of you well, but there are others that work for the VA that know that I have been pounding my fist, particularly about VA services in Central Alabama, since I got here. and I can go back through with you at another time when I have more time, all of the history related specifically to this VA center. It is a big stinky onion, and every time we peel back a layer, there's another layer there. And so I have to take this opportunity anytime I have an audience with you guys to speak on behalf of this issue regarding my concerns, and I'm taking full advantage of it here today. My constituents, our nation's veterans, they're not receiving proper and timely care. And I need to know what are we doing to ensure that they get it. And I just can't tell you here today how frustrated I am that we continue to be at the bottom. It just shouldn't be this way. And there should be more attention coming out of Washington specific to this healthcare system. And so I don't have a whole lot of time left, and I would love for you, whatever you don't answer here today, to continue this relationship, because I remain committed and I am not going to stop until these veterans are being seen and given care.
So, thank you for that. That falls under my wing. I am in clinical operations, so I am very committed to doing whatever we need to do in central office in DC to work with the VISN leadership to assist that facility there. And again, I would love to have a conversation with you. Absolutely. We have many resources that we have afforded the facility, and there is active work going on currently there. It's interesting to me when I look at their report, if you will. In some of the areas that they're excelling in, other facilities find very hard to excel in. And then the other ones, like you mentioned, many sites find it's easier to excel in. So I haven't quite figured out the actual magic button to push yet. But no doubt we are working on that, and I am in constant communication with the VISN leadership on that.
Sure, and Dr. Bull and I speak on a regular basis.
Okay.
And
Linda Bull, yeah.
yes,
Yeah.
and I mean, I can't tell you the amount of oversight that our office takes to make sure that our veterans are getting not only timely care, but the best care that we can get them, but we continue to fall short. I would love to set up some time with you, since my time here is expired. I would like to go over some of the things that continue to be a problem, whether it's on the sale data or not. There's some anecdotal things that you might be interested in as well. And I'm sorry, Madam Chair, I've overstepped my time.
Okay, absolutely.
Okay. Thank you, I appreciate
You
it.
bet.
I yield
Look
back.
forward to it.
I'm just going to recognize Mr. Bishop for 30 seconds on the same issue.
Let me just echo what Ms. Roby has said. That VISN and Caregiver serves my area also, and I have, countless veterans that go over and encounter the same kind of situation. In fact, my brother-in-law was treated there and had the same kinds of difficulties that are being described. So I want to echo that, join in that, and I certainly would like to have conversations with you about it.
Absolutely, thank you.
I mean, what Ms. Roby said is right. You can't have our VISNs on a bell curve where some of them it's okay that it's a 1 and some of them it's okay that it's a 10. And, we need to strive for 10 with every one of these service areas. So I'm not sure that I'm comfortable with you only coming in and talking to Mr. Bishop and Ms. Roby. So perhaps we'll have you, maybe we can do a more informal workshop so that we can get a better
Whatever needs to be
understanding.
done.
Because we haven't even had a conversation about long-term care in this subcommittee before. So, the hour that we have, unfortunately, is getting close because we're going to have votes called. But if we can maybe reconvene and continue the conversation, that would be incredibly helpful. Mr. Case?
Thank you very much. I'd like to follow up on 2 themes that have been coming out from a number of the questions thus far. One theme is the influence of different geographies, different cultures, different ethnicities on the available options for and limitations for the broad range of healthcare for our veterans. And the second theme has been really the need to introduce a lot more flexibility and a lot more options as fit the particular veteran, as opposed to kind of the the traditional, hey, we've got this big old hospital in the middle of a state, and everybody has to go there to get what they're going to get, and they only get what they get there, or maybe when they get older, they go into a big old long-term care facility. And that, I think we all are on the same page, that doesn't really work anymore, if it ever did work, by the way. But maybe we didn't know it then or didn't understand it. And I give it to you in the context of my own state, Hawaii, where we have 117,000 veterans, one of the largest percentages per capita of veterans. And we are an island state. So if you are a veteran that lives on the island of Hawaii, where I'm from, you cannot drive to Honolulu to get your care. You have to either fly or you have to get it in place. Same with the other islands. Even on the island of Oahu, which I now represent, you have limitations on the availability. You also have incredible advantages because in Hawaii, for example, we have one of the largest percentages of multi-generational families in the entire country. So it is in the culture to age at home and to die at home. And it is and focusing really on long-term care specifically, we've got a limitation on long-term care facilities. In Hawaii, we actually have the largest long-term care facility, which is 67 beds, on a different island in Oahu, where we have 70% of our vets. And we are about to build a long-term care facility already authorized, appropriated in the pipeline and accelerated for Oahu, which I very much appreciate. We really need to get that done. But I think what I want to ask you is, I think you're heading in clearly in the right direction of trying to provide better overall options for the delivery of care, medical care, health care, long-term care to vets in a way that works for them, not so much in the way that works for, some centralized bureaucracy. And there are lots of different ways of doing that. And my question is this: do we have sufficient legislative authority and flexibility under the law now to adjust overall to the delivery of alternatives, telemedicine? I'm huge on telemedicine also. I very much agree with my colleague on that, to adjust to the needs, not only across the board, but also by geographical, or for that matter, ethnical or cultural differences? Or do you believe that there are limitations in current law or regulations that we need to change legislatively in order to open up the kind of flexibility that I think you are advocating for? And if you are, I'm a fellow traveler on that, whether it be for Hawaii or for Texas or for anywhere else.
Nothing jumps to mind right away, but I'd like to go back, unless Dr. Boyd can think of it, but I think I'd like to go back and ask some of the experts that dig in the weeds every day when it comes to these authorizations, and get back with the group, because I'm just not conversant on any unless you...
It's a very good question, and it's a good one for us to think about as we mature what we hope is it's going to be a nimble process and a learning process as we listen to our veterans and have this choosing home idea. It's going to work. But the flexibilities that you're talking about, I do not know anything right off the top of my head that is in a disconnect to where we want to go. I'm all ears. I know we are. It's going to take all of us thinking about this and figuring out what are any barriers as we come along the way. So I would be open for that continued conversation.
Thank you for that.
Right,
and I would encourage you also to be open to those sometimes very subtle differences in VA populations and in the caregivers ethnically, for example. There are ethnic diversity and differences in Hawaii that are, I'm sure that there are similar ones throughout our country that may actually counsel a different availability of options in that particular area. Multi-generational care is a perfect example of that, although obviously Hawaii is not unique to that. But thank you.
Right.
Thank you so much. Looking around the table, nearly all of us represent southern states or states with disproportionately higher retiree populations. And so this is, perhaps except for Mr. Cartwright and no one else, actually, Mr. Hurd as well, and Ms. Bustos, who's not with us. But I think what we'll do is convene a more informal workshop and ask you to come back and bring some others with you so that we can get into these issues in more depth, and perhaps in a less pressurized setting where we can ask you some challenging questions, and then also make sure that we can have a better understanding of the breadth of the services available, how we can help our constituents access them, where you are in terms of the direction and the future. The takeaway for me today is that the VA still feels a little 18th century when it comes to the services that you provide, or at least the awareness that you are realizing with the constituency. And if I'm wrong, I'm thrilled. But I don't know. I represent a pretty big population of retirees who, that are veterans, and if I'm unaware of the services, then I'm quite sure that perhaps they are as well. So with that, I'm on it. With that, at conclusion to our only round of questioning for today, I want to remind members that our hearing tomorrow, which was originally scheduled with the VA Inspector General, has been postponed because of the 2 funerals that are taking place tomorrow. Our next hearing is now February 26th at 10 a.m. in 2359 Rayburn House Office Building with the Secretary of Veterans Affairs to conduct general oversight of the department, and we are adjourned subject to